positive and negative, and the perfectionism inventory. And again, all of these have subscales and subscales that are really not going to be that important to you, either. Certainly not as a sufferer of perfectionism, but even as clinicians, you're mainly going to be looking. To be honest with you, the measures are not going to be as important as your clinical analysis and your evaluation. So, I want to see how we're doing. So when do we stop?
12 noon.
12 noon, so we have an hour, a little bit, not quite an hour. Okay. So let's talk about perfectionistic beliefs. Now, these are things that as clinicians we see a lot and we work with a lot, helping people identify their beliefs. Here's one that's very popular. You ain't first, you're last. That was Ricky Bobby, the famous psychologist, Dr. Ricky Bobby. All right, well, that's not one of the ones that we actually study, but here are some from the Obsessional Beliefs Questionnaire, the perfectionistic scale. And so let's take a look at them. For me, things are not right if they're not perfect. Now that's sort of when we say not right. When you think about the concerns of perfectionists, sometimes they seem to be related to sort of social domains, like I don't want to look bad, or it would be horrible, people would judge me if I flunked the test, or, well, I should say, if I didn't get an A. They don't really, F, why would I worry about that? And this gets into some of the, what I would call super perfectionists that are just teetering between just being excellent and nosediving into dysfunction. I had a woman from the St. Louis Symphony who was in my office, and she was struggling with perfectionism. And naively, and of course, you know, to be in the symphony, you have to be kind of good. And so naively, I asked her, so are you concerned that when you play, and I'm just going to say the violin, when you play the violin that you'll hit a wrong note? She kind of laughed at me. It's like, no, I wouldn't ever play a wrong note. So we got into what her concern was, is that it wouldn't be perfect, which is different than playing the wrong note. I mean, obviously playing the wrong note is not perfect, but that's not the concern of this woman. It is that the note would not be struck at the precise millisecond with the perfect resonance in the bow, just the right vibration, that if she didn't do that, 99.9% of the human race would never notice, but maybe the conductor would, or one of the violinists next to her. So that's what I call hyper-perfectionism. Your standard is so, and you actually meet the standard most of the time. But it is sort of hard to think about meeting it all the time. That's pretty tough. So if I don't do a job perfectly, people won't respect me. So there's one that's a little more social in orientation. Even minor mistakes mean the job not complete. So for many of us, if any of you work, and I know that some of you clinicians work, some, not all of you, but any of those who work at anything, whether it's parenthood, an outside job, whatever, you know that you can't do everything perfect. And the reason I can say that with confidence is we already asked any perfect people to leave, and they're gone now. So I know the rest of us can't do it perfect. So what do? We compromise. We say, all right, I'm not going to do it. All right, we're supposed to bake a meal. I didn't have time for this potluck, so I'm just going to run by the Chinese restaurant and get some, whatever, bring it, or whatever it is. And so we make those compromises, and we have to, because we have to make priorities about what we're going to do better than other things. But this allows no, even minor mistakes means a job's incomplete. That allows no opportunity for mistakes. Things should be perfect according to my own standards. And so again, that sort of gets to the just right stuff. So we've talked about how fears of perfectionists sometimes are related to performance in the outside world and how people will judge them. But it's also related to internal feelings, because which is often underestimated. So that not right feeling that is so intolerable. And you'll have patients who will say, I'm not really worried about what my teacher thinks, to be honest with you. It just doesn't feel right to me. I can't turn it in. It's not right. And it is a feeling. Now, there still is fear involved in that, but it's a fear of the feeling, not so much fear of the teacher will look down on them. In order to be a worthwhile person, I must be perfect at everything I do. And I must be perfect and everything. So you can certainly see the potential for dysfunction there. I must keep working at something until it's done exactly right. And again, that often refers not to necessarily an objective standard that we could all identify, but the feeling that it's right. For me, making a mistake is as bad as failing completely. There's that all or nothing thinking. So if it's not perfect, I must be the best at things that are important to me. If I can't do something perfectly, I shouldn't do it at all. Do you realize how many things would not happen if we all had to do things perfectly or not do it at all? There'd be a lot of things not done. These are items from the Obsessional Beliefs Questionnaire. So I will just say clinically to clinicians, we don't use those perfectionism questionnaires because we use the Obsessional Beliefs Questionnaire because it captures other things besides perfectionism. And so we don't want to burden our patients with just needless forms to fill out. So we want to make sure that we're kind of efficient in what we're asking them to do. So with the OBQ, you get perfectionism, but also intolerance of uncertainty and beliefs about controlling thoughts, and things like that, and over-assumption of responsibility. So we don't want to. We want to be thorough, but we don't want to overburden our patients as well. So I want to just say that for this talk, I'm not having to qualify myself. When I say perfectionism or dysfunctional perfectionism, I'm saying the same thing. From this moment on, perfectionism means it's the bad stuff, not the good stuff, just so everybody knows. So, I thought this was very apropos. So I want to talk about the clinical perspective, because most of us, that's what we're really concerned about, not as much on the academics. I think there are kind of two priorities for me as a clinician in what we want to learn about perfectionism. One is, if we conceptualize it as a personality trait, then could perfectionism be established as one of the risk factors for developing conditions like OCD? And in other words, you have a perfectionistic personality prior to the onset of the OCD, but that then predisposes you to developing it. And then if we're going to talk about perfectionism as a disorder, what are the clinical manifestations and what are the treatments for clinical perfectionism? So I don't know, for some reason my white fonts are coming out sort of low, but so what I wanted to say was that on the box on the left, we can think of perfectionism as a personality trait that may lead you to be more likely to develop perfection-related disorders. And then other predisposing factors might also have genetics, other things might also play a part as well. And who knows, the personality trait itself may even be influenced by genetics. We don't know. But I wanted to make this distinction between personality, an ongoing personality trait, versus a perfectionistic disorder, because they're not necessarily the same thing. Now, remember these two factors. Let's go back to perfectionistic strivings versus concerns. Okay, strivings is more adaptive. You see this guy working hard on his computer. He's not stressed out. He's just being productive. And then you got this guy fretting down here. So the reason I'm reminding you of that is because I want to just kind of talk a little bit about the research on the effects, or at least the things that are associated with perfectionism in general. So perfectionistic concerns, negative perfectionism, is not good for you, it looks like. So it is associated with more negative affect and depression, whereas positive perfectionistic strivings is correlated with positive affect, with feeling better and feeling a sense of well-being. And perfectionism is not good for your health, in case you were wondering about that. So if you got a choice, I mean, like say no on the perfectionism thing, would you? Because not good. So you have much more, you have a much higher propensity to have comorbidity, medical comorbidity, if you are perfectionistic. Again, the negative kind. And GI disorders, migraine headaches, and cardiovascular illness all have more specifically been associated with perfectionism. But you also have a greater likelihood of having medical problems in general. Now, we could all wonder why that might be, but if you think about it, if you're perfectionistic, you're certainly stressing your nervous system with anxiety, and that may have an effect through that pathway. If you're not taking care of yourself, you're not nurturing yourself, you're not inclined to do things that are pleasurable or relaxing, because those are seen as a waste of time. And I think all the clinicians have probably dealt with patients who would, when they tried to get them to balance their life a little bit, the patient would say, well, I can't do that, that's stupid, it's a waste of time. And then you're trying to help them understand, you know, doing something to help your health, I don't know if that's really a waste of time. But you do have to show that there's a productive outcome. It's like you have a better sell for self-nurturing to a perfectionist to say, you know, there's evidence to support that your health may improve. And then you'll have more energy, and you'll be more efficient at work. And you'll get more done per minute than if you're burned out and blah, blah. That's a much better sell than you really need to take care of yourself. Come on. That doesn't go over well usually. Well, perfectionism, it's hard to find a mental illness that perfectionism isn't associated with, to be quite frank. Perhaps schizophrenia, bipolar disorder, but the whole range of anxiety-related disorders and mood disorders, perfectionism is higher in those groups. Now, we don't know what causes what. Maybe you become perfectionistic after you get depressed. I doubt that, but we can't say for sure. But it certainly makes sense that a perfectionistic lifestyle would lead you to anxiety versus depression. And think about it. When you have a certain outcome, a narrow range of outcomes that you find acceptable, and often about things you can't control, when you have this narrow range, and there's so many things, the way things could turn out that wouldn't fit that narrow range, it makes sense that you're going to be worried more about that, because there are too many unacceptable outcomes that are possibly to happen. And so your brain's going to trigger the alarm of, uh-oh, look at the probability of all these, it could not turn out the way you want. So those things are, make sense that perfectionism would be associated with anxiety-based conditions. And the self-criticism, certainly, you could see how that could lead to depression. But those of you clinicians can look at these disorders and you can think of how perfectionism would relate to all of these. And I even put etc. in there because I know I missed some. Then we think about perfectionism, and this is kind of what I was talking about before, the intolerance of uncertainty. And then the relationship between anxiety. So in perfectionism and intolerance of them, and that measure that we just talked about, the obsessional beliefs questionnaire, perfectionism and intolerance of uncertainty were two separate subscales on that form until the psychometric research found that they tended to correlate so much that there was no need to separate them. They were joined together as a single subscale called perfectionism and intolerance of uncertainty. So you can see, so people who tend to be perfectionistic are also highly intolerant of uncertainty. They have uncertainty intolerance, is what we call it. And especially about the things that they care about. And then, of course, more than a couple of things that we deal with in life have something called uncertainty tied to it. There are very few things that we're certain about. Actually, I can't think of any you can be completely certain about. I guess they say death and taxes, but okay, beyond those two, not too many. So I always played with this, the idea that, you have all these, in our field we tend to have a spectrum of disorders. OCD was seen that was going to be the OCD spectrum disorders. Now that it's the OCD and related disorders got changed because the spectrum, the word spectrum, implies more relationship between those disorders than really the research supports. So hair pulling is very different than OCD. They're not the same thing, but they're in the same category, but they're kind of related because they have repetitive behavior, but they have very different features to them. By the way, I cannot work with hair pullers because I have too much countertransference. So, for those of you who are not clinicians, I get upset because they're pulling hair. I have so little. So I always thought about the perfectionism spectrum disorders, all these disorders that, and as clinicians, think about the times where the perfectionism just hits you in the face, and then you sort of try to decide which diagnosis to give, right? It's sort of a secondary consideration. Well, a little social anxiety, a little OCD here, a little that, yeah, they're depressed too. And then also, we don't really have an accepted diagnostics for the topic of my talk today. In other words, if somebody said, well, is academic perfectionism, for example, is that a disorder? It is disordered, but it is not a recognized disorder. We clinicians have to stick it into one of the existing labels that are in our nosology. There isn't a section on academic perfectionistic disorder. So we don't know where it's going to all hit, but it's clearly a disorder. I mean, we all know this, yeah? We just have to figure out what to do with that in the years ahead. Will we put it all under OCD? I would suggest that that's not a bad place for it, to be honest with you. But if not, we could have a whole separate category called perfectionistic occupational academic disorder or something like that. I don't know and really don't care what we ultimately end up with. I'm more concerned about the treatment and that we get good treatments to folks who are suffering from this, because this is not an insignificant disorder, as we're going to jump into in a little bit. This can really be not just impair the individual, but the entire family can be devastated by this. So, we don't have a good diagnostic categorization system that we all agree on. In the meantime, for those of you who are clinicians, if you're suffering from it, you don't care what diagnosis it gets, you just want to get better. For us clinicians, I want to suggest to you that an OCD framework might be the most useful in most cases for this. So could we use the OCD model, including the treatment model, to treat effectively these conditions? And the answer is yes. And you know how I know this? Because I said it in 2015 in August. I said these exact words. And now some people think it's weird that I quote myself at another time and another place. If you're honest, you'll admit that seeing it said somewhere else at another time, it somehow makes it more impressive than I just say it now. Oh, he just said that now. I don't think that even generalizes past New Jersey. So you know it's true if I said it at the foundation meeting in 2015. By the way, has Eric Sturridge ever come up here at this talk?
He's on our list for invitation.
Oh yeah, he'd be great. So he told me, I had done another version of this, and Eric said, oh, I love that, I'm going to use it. I'm going to quote myself at another place in one of my talks. And then he came back last night and he said, I didn't, nobody laughed. What are you doing? How does it work? I don't know. I still can't figure out why it didn't work for him, but yeah. Okay, so let's look at OCD and perfectionism, and let's go with the idea that maybe as clinicians this might be the most useful way to think about perfectionistic disorders. So what are the two main symptoms of OCD? Who knows? Anybody? A small rash on your left leg and headaches. Those are the two main symptoms of obsessions and compulsions, right? I could have given you a hint. What are the two main symptoms of obsessive compulsive disorder? Okay, so avoidance of things that trigger anxiety, obsessions, and engaging in repetitive behaviors that are designed to neutralize anxiety, compulsions. What are the two main features of dysfunctional perfectionism? Procrastination, avoidance of tasks, or taking an excessively long time to complete the task, and that's always because of the compulsions. So, you really, if you think procrastination and taking too long are kind of the two main features. This is why, by the way, that many times, and I always think of kids more dramatically, but certainly adults, are mislabeled as by their teachers or the schools as being irresponsible because they turn in their stuff late or they don't turn it in at all. But they're not turning it in late or not turning it in because they're irresponsible. It's the reverse. They're so responsible that they can't stand turning it in when it doesn't feel right. And so they'd rather, completely illogically, they know it, you're going to get an F if you don't turn it in at all. Wouldn't a B or a C be better? No, because their priority is that right feeling. I got to get that right feeling. It's like telling an alcoholic, don't you know there's some downsides to drinking? Really? You know, you're going to pay for this tomorrow. Oh, really? I didn't know that. Okay, I'm putting that beer down because I don't want to have a hangover tomorrow. So the focus is on the immediate, I got to get the feeling right, or I don't want to feel the anxiety trying to start the project, so I just put it off. So what is the two main features of OCD treatment? Exposure, response prevention, right? Exposure is to the obsession. Response prevention is focused on the compulsion. So what do we do if we treat perfectionists. We expose them to the tasks they procrastinate doing. But, and this is key, they have to have a plan for response prevention to contain the perfectionistic compulsion. It's not just having them do homework. That is not treatment. They have to learn. This is really critical, as you'll see we get into this more under academic perfectionism. They both shared this issue, as I mentioned, of intolerance of uncertainty, big issue, and the just right feelings, that gotta have the right, just right stuff. Not right. There's a type of OCD, I think most of you know, called, sometimes they call it just right OCD or not just right OCD, or OCD of incompletion. In other words, something does not feel complete, and I must do this until it has that sense of completion. All right, let's talk about the kids now. I say kids, but these can be big kids too, going to college. Here's the very first case I treated. Early stages of math anxiety. By the way, he's doing well now. He got a new cave. He's successful at his work. He was able to buy a new cave. And all right, now no jokes, Alan, about my age. Okay. I want to tell you about Gloria, because Gloria exemplifies to me the pinnacle of academic perfectionism. And as you can see here, she's fretting away at her schoolwork. And what is in that but the Gloria Medical Center that she is someday going to own. So you all know the downward arrow, you clinicians, right? So, but for those of you who are not clinicians, the downward arrow approach is when you're trying to get to the bottom of someone's fear. So if you said, well, why do you not want to go to that room? Well, because there's people in there. Okay, and if there's people in there, what does that mean to you? Well, it means that I could make a mistake. Okay, and if you made a mistake, what does that mean to you? Well, then they might notice it. Okay, and if they notice you making a mistake, then what might that mean? Well, then they might judge me as being a bad person. Okay, and if they judge you, you get the idea. That's a downward arrow. You just keep going till you try to get to what's really the core fear. What's driving all this? So with Gloria, what, and by the way, I'm just going to tell you ahead of time, I am not exaggerating one bit before I tell you this, okay? I promise. And I've never lied to you, have I? Okay. So why do you fret so about your score on this test? Well, because if I don't get a perfect score, I might not get an A in class. Okay, what would that mean to you? Well, if I don't get an A in the class, then I wouldn't have a perfect grade point average for the year. What would that mean to you? If I didn't have a perfect grade point average for the year, my overall grade point average, Gloria, I want to tell you, I didn't tell you this, she's 13 years old. Go outside and play. It's just not right that a 13-year-old should be grappling with this. Okay, back to the story. If I don't have a perfect grade point average in high school, then I won't get to the college that I must get into. I'm just going to keep going. I'm going to skip mine and then what, so I'll just go tell her story. And then if I don't get into the one single college that I must get into, I might not get into the medical school that I've already decided I must get into. And then I would not be able to be chief, then I wouldn't get the residency that I wanted. And I would never be able to be the chief resident of that residency. And then I would not get the appointment at the medical center I've already decided that I must work at. And my chances of being chief of staff of the medical center, of that particular medical center, would not happen. So one test for this girl determines whether she's going to be the chief of the medical staff or whether her dreams of that are ruined. Imagine living that way as a 13-year-old under that pressure. I kid you not, that's exactly what she said. I consider her the queen of my perfectionistic patients. I don't think I've had anybody who had such a distal outcome tied to every little movement she makes here as a 13-year-old. So you can imagine she's not going on recess. She's not playing. She's not talking to her friends. She's studying. Didn't sleep a lot of the times. Sometimes the parents, other parents would sort of jokingly say, oh, I wish our kids would study all night. I wish we had that problem. No, no, you don't get it. She's sleep deprived. She has no life. She's cranky. She's unhappy. She's miserable. You don't want that. So, perfectionism in academics, not so good. Here are a few highlights. Academic perfectionists have more anxiety before tests. They have lower performance scores to people of comparable IQ. They have, after the test or after the schoolwork, they have more self-criticism and negative affect. And they put off tasks longer than other folks. They procrastinate, as we already have demonstrated. And actually, even faculty have fewer publications, and that really upset me, and high-impact publications when they're perfectionistic. So what are the compulsions that are common? Rereading, erasing, and then rewriting, over-researching, mental editing. So mental editing is they're trying to write the paper in their head perfectly before they even get a draft down. And of course that doesn't work, it shuts them down. They're doing too many steps of the paper writing at the same time. And they're not dividing it up into manageable steps. Checking, of course, and reassurance seeking all are common symptoms of this. I want to talk a little bit about the dilemma. So I've already mentioned that this idea that if I'm not perfect, then I'm a bum or I'm irresponsible. But I want to talk about, let me see, what's my next slide here? Okay. So we all know this is epidemic. I have to think that my fellow clinicians here in New Jersey have the same experience we are. We are getting referrals